Great, yeah. Thank you very much. Good morning, everybody. I've been asked to address the question of how to feed our patients in the intensive care unit. And I'm conscious of the fact this is a very controversial issue. We all provide nutrition. We all consider nutrition to be an essential part of modern critical care. But it's very clear that the protocols in different hospitals vary. There are differences between guidelines. And it's also clear that some of us have very clear, strong views, which may sometimes be opposing. So in the next 20 minutes, I'd just like to give you a brief overview of some of the issues and really follow and conclude with latest recommendations. These are my disclosures. They will not affect what I'm going to say, but in principle, I like nutrition for myself and for patients. I'm on the pro side. So as you all know, malnutrition is bad. Malnutrition is a common problem in critically ill patients, and it's associated with poor outcomes. It's also clear that patients not only become malnourished when they're in our care, a proportion of patients will already be malnourished before they come to us. It's clear that critical illness is an inflammatory condition leading and contributing to some of the nutritional and malnutritional aspects we see. And in principle, when it comes to nutrition, I think there is a key principle, which is that we don't want our patients to starve, but it's clear we shouldn't overfeed them. That's bad too. During critical illness, it's quite challenging to provide the right amount and the right type of nutrition, mainly because so many normal pathophysiological processes are completely disturbed. The sympathetic nervous system is overstimulated. There's a dysregulation of normal endocrine pathways. There's obvious insulin resistance, which then leads to hyperglycemia. There is resistance to anabolic factors, and that means that tissues, in particular muscles and lean body tissue, break down. This obviously leads to muscle wasting. And as a result of tissue and protein breakdown, we release amino acids into the systemic circulation. It's been clear that muscle breakdown and protein degradation occurs faster than the body is able to generate new proteins. They are in competition, but protein breakdown and protein degradation occurs at a higher speed. And obviously with nutrition and with all the other things we do during critical illness, we try to keep up with this process. But as protein and other lean tissues break down, substances get released, in particular amino acids, and they then get used again to produce different types of energy. For instance, amino acids get used to produce glucose and some other essential fats. And the whole various processes of energy production which occur during health, as we're sitting here in this lecture room, are dysfunctional. They're either inhibited or limited. And different processes take over, stimulated by the nervous system and by altered endocrine pathways. So, as I've already said, ideally, we want to make sure we want to keep up with these destructive processes. We want to keep up with the muscle breakdown. We want to keep our patients fed, but don't want to overfeed them. So it would be nice to know how much patients actually need during critical illness. And it's been recommended that patients that we determine and calculate their energy expenditure. There are three methods of doing so. One is to essentially measure energy expenditure using indirect calorimetry. And that can be done. It's quite intensive, labor intensive, but it can be done. And there are intensive care units which do this regularly. There are also numerous formulas which can help you determining energy expenditure. And I've just listed one of these formulae, the Harris and Benedict formula, but there are others. And these are some of the formulas which some of you may use, which some of our dietitian colleagues may use. And then there is a very simple way of doing it by essentially estimating it and having a rough estimate of 25 mils per kilo per day. And the question is one better than the other, or does it not really matter? The TICACOS study tried to establish this and tried to explore whether it was important to estimate energy expenditure accurately in critically ill patients. So the investigators performed a single-center randomized controlled trial in 130 critically ill patients who were sick enough to have an expected stay of at least 3 days in the intensive care unit. And they were randomized to, all of them received enteral nutrition. They were randomized to energy expenditure calculation using either repeated calorimetric measurements versus simple estimate using a formula of 25 kilocalories per kilo per day for everybody. And the aim was to provide the target nutrition according to these two strategies. And if this was not possible with enteral nutrition, then parenteral nutrition was allowed to meet the target. And the key findings of this study are really two. There are two main results. One is, independent of which method you used, in patients where the target nutritional requirement was met, they had a better outcome. They had a significantly better hospital outcome. And then secondly, in an intention to treat analysis, they looked at the outcome of these two groups. And the really enlightening and interesting result is that all outcomes were slightly better in the control group, where essentially dietitians and clinicians had just done a rough estimate saying, well, everybody needs just 25 kilocalories per kilo per day. They were significant for length of stay in the intensive care unit and infectious complications, but as you can see, the trend was really better with regards to all different outcomes. And so maybe this what most of us do in real life, having a rough estimate of estimating that people need 25 kilocalories per kilo per day, is acceptable. Another area of controversy is this concept that patients should be fed right from the beginning, the concept of enhanced nutrition right from the start, enhanced nutrition within the first 48 hours. And if you go to the literature, you'll find, first of all, key opinion leaders with very opposing views. And you'll find a lot of studies which show, again, conflicting results and opposing results. You'll find studies which show very convincingly that early nutrition is beneficial and results in better outcomes. And you'll find studies which show the opposite, showing that those who were fed right in the beginning had worse outcomes. And that's where the whole notion of hypocaloric feed has come up. But people have argued that during critical illness, it's okay to be starved. In fact, it may be better to enhance autophagy and allow the body to cope with the stress of critical illness. Darren Hayland is an expert in nutrition from Canada, and he tried to address the question. His publication has just come out in Critical Care Medicine. So the main aim of this study was to explore whether enhanced nutrition was beneficial. They performed a large multi-center prospective observational study, included 202 intensive care units. And they enrolled, as you can see here, more than almost 4,000 patients. Actually, more than 4,000 patients, of whom the majority were in the intensive care unit for more than 4 days. The key findings of this paper are that enhanced nutrition was beneficial in patients who were at high risk of malnutrition, as judged by a nutrition score, and who stayed in the intensive care unit for longer. They clearly benefited from appropriate, adequate nutrition right from the beginning. This was associated with a lower mortality and a shorter stay in the intensive care unit. In patients who had a lower nutritional risk or stayed in the ICU for shorter, there was no significant benefit from receiving full nutrition right from the beginning. And I think this is an important finding, certainly one of the largest studies. I tried to figure out what this means for clinical practice and read one of the editorials which go with it. And essentially, when we deal with patients on day one, although we have our clinical experience and we may be able to make a judgment, but in reality, we are unable to exactly predict how long the patients will be in the intensive care unit. And so the general advice for clinical practices from this paper and the associated comments that we should just aim to feed our patients properly and adequately right from the beginning, and accept that short stay patients or those with a lower risk may not get an immediate benefit from it. But at least we help and support those who have a higher risk of malnutrition and may end up in our intensive care unit for 12 days or more. Obviously, there are two main types of feeding our patients. That's enteral nutrition versus parenteral nutrition, or a mixture of both. Clearly, there are major benefits with enteral nutrition. We're all aware of the beneficial effect on the gut integrity and gut mucosa. But it's also clear that it's not always feasible to feed patients. Patients may have numerous reasons why we can't give them enteral feeding, or they may just not tolerate it. And often patients who are sicker, or the sicker patients are, the more difficult it is or can be to feed them adequately in the beginning. Parenteral nutrition is the alternative. You will all be aware of the potential side effects and concerns. And it's obvious, with that in mind, it was important to see that the calories investigators in the UK performed a study to explore whether enteral nutrition was superior to TPN in the beginning of critical illness. And in this large randomized controlled trial, patients were randomized to early enteral nutrition versus TPN for at least 5 days. And the nutrition started within 36 hours of ICU admission. 2,400 patients were enrolled. And as you may know from this publication, which was published in 2014, there was no difference between the two groups. There was no difference in 30-day mortality. There was no difference in infections and no difference in adverse events. On the positive side, there was less hypoglycemia in the TPN group and there was less vomiting. And some people have interpreted this study as a negative study, which clearly shows no difference. In my opinion, it's a study which shows that in modern critical care, TPN is safe. And if we have to give it, because enteral nutrition is not possible, at least based on this study here, we are not subjecting our patients to any unnecessary risk as judged by this paper. Clearly, in this paper, there was no difference in the adverse events or risk of infections. And I personally found this paper reassuring. So the question was what, when, and how to feed our patients. Now, I want to finish with some official guidelines, realizing that there is a lot of controversy. And the European Intensive Care Society and the Intensive Care Medicine Journal must have known that I had to give this talk, because they've just published their official guidelines, which have just come out in the last 6 weeks. And that was reassuring for me. So this is the guideline, which you'll now find on the web. And as you can see, an expert committee of experts in the field from various different specialties reviewed the existing data to compare early enteral nutrition, that's within 48 hours, with early parenteral nutrition versus delayed enteral nutrition. And it's a very detailed paper. It's a long paper, and they have to be congratulated, because not only did they look at all the data, they also performed some additional analysis to really nail down whether there was a difference and how to feed our patients properly. And I'll just give you the summary of this paper. It's worthwhile reading. Bottom line is, in their opinion, early enteral nutrition is the first line type of nutrition for critically ill patients, rather than early parenteral nutrition or delaying enteral nutrition. They felt there was enough evidence to recommend early nutrition. And as I said, enteral nutrition is the first line nutrition. They then went on and looked at numerous different patient groups who are often difficult to feed often for different reasons. And these are groups of patients where clinicians may feel it's okay to starve them for a bit longer, it's okay to wait a little bit longer, it's okay to delay things, or it is just generally hard to feed them. And they felt that all of these groups, as listed here, benefited from early enteral nutrition. They accepted and felt there were also a group of patients in whom it was okay and actually advisable to delay enteral nutrition. And these are the people as listed here. And you would probably agree that patients with uncontrolled shock or severe multi-organ failure with severe mitochondrial failure or bowel ischemia may not be able to tolerate enteral feed immediately. And they accepted that and recommended that enteral feed should be delayed until the situation had improved. And then there should be a good attempt to start and enteral feeding and to achieve the enteral nutrition targets. They also spent a lot of time talking about discussing prone positioning, and felt that patients in a prone position had no reason not to have any enteral feeding, and it should be attempted. So these are the current latest guideline published within the last 6 weeks from the European Intensive Care Society. I thought it was worthwhile also looking at other guidelines, and I chose the ASPEN guideline because it's often used, certainly in the UK, by our dietitians. And they revised their recent guidelines and published their up-to-date guideline at the end of 2016. And I'm going to mention them briefly because there's a lot of similarity, but there are a few differences. The bottom line is they also agreed that it was important to feed people properly, that it was important to assess them regularly and to assess their energy expenditure. For some reason, they thought indirect calorimetry should be recommended as the first-line measure, but if this was not possible, then any other method would do. This is clearly in contrast to the TICACOS results. They recommended enteral nutrition over PN, over parenteral nutrition. They believed also that early enteral nutrition should be aimed for. And like the European Intensive Care Society, they acknowledged that certain patients may not be able to tolerate feed, in particular those with hemodynamic instability or severe shock, and that it was important to achieve the nutritional goal early. They, in contrast to the European Intensive Care Society guideline, have an extra section, quite a long section, on additional feeds, additives, special formulations. And this was quite interesting to read. For a start, they agree with the European group that parenteral nutrition should be considered early if enteral nutrition was not feasible, but certainly in high-risk patients should be considered early. In low-risk patients, based on nutritional assessments, it was okay to delay it for a bit longer. They looked at immune-modulating enteral formulations, and these are formulations which contain arginine and omega-3 and various nutrients which are considered to be beneficial and have certainly been shown to be beneficial in very small, tiny studies. And they thought they shouldn't be used routinely, but be considered for severe trauma or traumatic brain injury or post-operatively. And this was very surprising to me. Certainly that's not what I do. And I don't, in the UK, I don't know anybody who uses these immune modulating formulas. So I spent some time reading their recommendations, and they accept that the level of evidence is low to very low. And they can't really give you a good reason apart from saying, well, it could be, in theory, be helpful. But their recommendations are quite clear. They say, in patients with severe trauma or traumatic brain injury or post-surgery, consider the use of these formulations. So that's not what I do and what is current practice in the UK. Finally, they looked at probiotics, and although they are considered to be safe, they agreed they were safe, they felt there was not enough evidence to recommend them routinely. They didn't think there was enough evidence to recommend glutamine. And for various subgroups, in particular, the people who may have unusual metabolic problems, like patients with liver failure or acute kidney injury or those on the filter, they felt that standard enteral nutrition was absolutely adequate. They looked at the evidence for adding various trace elements and accepted that patients with critical illness often were deficient in these trace elements, but in this case, they felt they couldn't make any recommendation. So they had been quite happy to make a recommendation for immune-modulating nutrition, although there was little evidence on conflicting evidence, but for trace elements, they felt not in a position to make a united recommendation. So in conclusion, at this time, currently, early enteral nutrition is considered the first-line nutrition. Early parenteral nutrition should be considered for patients who are at high risk, high nutritional risk, in whom enteral nutrition is not feasible. In patients with low risk, with a low nutritional risk, parenteral nutrition should be considered after 7 to 10 days if the nutritional needs are not met. As I've already told you, ASPEN, the American guideline, recommends immunonutrition with very low evidence to back up the recommendation. And for special types of patients, there is no recommendation for any special feeds. So standard enteral nutrition should be sufficient based on existing guidelines. Thank you.